Thank you, Dr. Nguyen. Thank you, Dr. Ali. And thank you to SAGES for allowing me to present my material. I have nothing to disclose. Postoperative nausea is a significant source of patient discomfort and can be a common cause of increased length of stay. The incidence in the literature can range between 20 to 30% and may actually be higher in our bariatric population. Dexamethasone has been studied in patients undergoing laparoscopic cholecystectomy and a variety of head and neck procedures, including thyroid procedures, strabismus procedures, but it has not been studied in the bariatric population. Part of this may be out of concern for the steroid use and its possible increasing in incidence of anastomotic leak in our bariatric patients. We proceeded to perform a prospective, randomized, double-blind, placebo-controlled trial at our community hospital. Out of 172 patients that we performed gastric bypasses on in a period of 18 months, 84 patients actually proceeded to go on study. Dexamethasone at 8 milligram dose was given at induction by the anesthesiologist, or a similar dose or actually similar volume of saline also given at induction. The anesthesia regimen was standardized, as well as the operation. Postoperatively, in the PACU at 6 hours, 12 hours, 18 hours, and if they were still in the hospital at 24 hours, a visual analog scale was administered by either residents or nurses. Here's our anesthesia regime. Of note, at induction or in the pre-op area, a scopolamine patch was given to the patient and placed on the patient. The study drug was given again at induction or a saline dose. The maintenance of anesthesia was also standardized, and at emergence, they all received Antimet. The procedure was a 15 cc gastric pouch, a 100 centimeter roux limb, a 2-layered hand-sewn gastrojejunostomy in an anticolic fashion, and a leak test at the end of our anastomosis at 2 liters was performed. Our patient population, fairly similar ages, 44 and 45. The male to female ratio weighed heavily on the female side, and the average BMI was 49 in each group. The percentage of patients reporting nausea. In PACU, 45% in the dexamethasone group, 53% in the placebo group. At 6 hours, 28% in the dexamethasone group and 38% in the placebo group. 12 hours, 12% in dexamethasone versus 28% in the placebo group. And at 18 hours, of note, this is when patients are either being evaluated for possible discharge the next morning. 9% in the dexamethasone group reported nausea versus 20% in the placebo group. And at 24 hours, very few of the dexamethasone patients were actually in-house at this point. 27% were in the placebo group. Our mean incidence of nausea in the dexamethasone group was 18% versus 34% in the placebo group. In addition, there were no anastomotic leaks. There was no difference in the length of stay, 19 hours in the dexamethasone group versus 22 hours in the placebo, and there was also no difference in the reported pain scores. In conclusion, dexamethasone 8 milligrams given at induction is effective in reducing postoperative nausea in the gastric bypass population.
Thank you for that presentation. This paper is now open for discussion. Please come to the microphone if you have any question.
Pavel Sabasavs from Hartford, Connecticut. I commend you for performing a randomized study. My question is, what is your definition of nausea? Because you said you used visual analog scales. You didn't present any of that data. So anybody who reported a nausea score of 1, would that count as a nausea patient?
The nausea scale actually was from the nursing literature, and it's a scale, it's similar to the FACES scale. Nausea of 1 is very minimal. In other words, the patient describes having a slight discomfort but is not requesting medication. 2, the patient's uncomfortable and is requesting medication. So a nausea of 2 or above is reported as nausea. This scale goes all the way up to 5, where the patient's actually vomiting and actively retching.
But your presentation was based on the percentage of patient with nausea. You didn't really show us, are these mild nausea or severe nausea?
That is correct. We do have that data that actually will be presented in the paper. But you're correct. There is mild versus severe nausea, and the severe nausea was decreased in the study population, less so in the mild nausea population in the range of 2 to 3.
Ed?
Ed Phillips, Los Angeles. I'm worried about the statistical power of your study. What were the ends? Because you showed percentages, but it might have been 2 patients. You didn't show the number of people nor the general power. And what statistical analysis, in fact, did you use?
We used a student's t-test. This was powered for the incidence of nausea. It was not actually powered for leaks. So there are 84 patients, and I don't have the exact numbers with regards to how many patients were in-house at 24 hours. However, we did look at the percentage of patients present in-house at the 18-hour mark, which was really the time change as to when the patient decided to stay or go home, really. And at that point, greater than 10%, greater than 90% of our patients were in-house at 18 hours.
Last quick question. I noticed everyone got scopolamine.
That's correct.
That's rather unusual. Was there any testing done on the differential response to scopolamine among patients? Because I know that there can be considerable difference.
With regards to how that
affects nausea.
We did not study how scopolamine affected nausea in this patient population. It was standardized for all of our patients to receive that.
Dr. Zalamea, if I may, you said that you had a regimen, an anesthetic regimen. I noticed in there you said that you used LR as your fluid, but you didn't tell us about volume. I mean, clearly volume resuscitation is associated with nausea. Did you have a particular volume goal, a milliliter per kilogram for the patient, or a certain number that you targeted, or was it just variable for all patients?
It was actually variable for the patients per anesthesiologist. We did ask them to come up with a anesthesia regime, and this was their regime. But when we looked at the amount of volume given our bypass patients, it was fairly variable.
So with this information, are you routinely giving dexamethasone to every patient undergoing bariatric surgery now?
Yes.
Is that including sleeve gastrectomy, everybody, or just Roux-en-Y gastric bypass?
We don't perform sleeve gastrectomies. We only do Roux-en-Ys. So in this time period, we've been performing those for 5 years now at Cottage, and we have for the last, now since this study, have been giving dexamethasone.
Okay, and in that population, have you observed any leaks? Because that would be more number than your study.
Correct. No leaks.
Great. Thank you very much.